Hi, welcome. I'm Mary Minetti with the Institute for Patient and Family Centered Care, and I'll be moderating today's discussion. We're going to wait just a couple minutes to let everybody have a chance to get logged in, but I appreciate you joining us today for this very important conversation. And if you can, as Maureen Hickson did, chat in your name and where you're from, that would be great. Thanks. It's very exciting to see all of you from around the globe, actually. Got some people from the UK and Canada and States. Thanks for joining. I'm going to go ahead and kind of set the stage and then we can get started. I'm joined today by my colleague Marie Abraham, who's the Vice President of Programming and Publications, and she's going to be our chat monitor. So she'll be looking for questions, she'll be helping respond to things that come up in the chat. I'm also joined by Natasha Reed, who is our registration and database manager, and she's kind of the technology person behind the scenes who's really helping us out, as well as Ushma Patel, who is joining us because, and you can go to the next slide, Natasha, because there were so many people that wanted to join this conversation and listen in, we had to go to the webinar mode rather than just the conversation mode. That doesn't mean we're going to be presenting, but it does mean that we can't see all of your wonderful faces, and I regret that. It lets us have more than 100 people join, and we had about 150 want to be part of this conversation. So we had to give up the opportunity to see your lovely faces. We're going to use some polls to learn about all of us and your experiences. Our goal really in this time frame is to really learn from each other. The good news is the conversation is going to be recorded, and those resources and recordings will be loaded onto PFCC Connect in a conversation folder under the subject community COVID-19. And if, as we're having a conversation, you have resources and ideas to share, and you may not be in a place where you can share them verbally, you may be sharing an office. Well, actually, probably nobody's sharing an office right now, but you may not have the audio capability. You can always chat those things in. What you may notice is that that we put everyone on mute. However, you have the ability to unmute yourself when we get into the conversation part after I've kind of set the stage. And that's just a matter of going down to the left bottom of your toolbar and clicking on the red line that's across the microphone. So that's how we're going to manage the time. We're going to start with the first poll. And Natasha's going to share it with us. I made it a fairly long poll. So it's going to basically, you can choose a couple options. You can choose what your setting in your environment is and also what your role is. So as soon as that poll comes up, you'll be able to see it. These are the kinds of questions that it's asking. And Jennifer, I can certainly speak louder. I also encourage you to look at your audio and see if you can also increase your sound in your computer if you're using your computer. So what I'm wondering, Natasha, is are we not able to get the poll to work?
I have it launching right now. So let's see.
There's always trade-offs with technology. Well, Natasha's trying to get oh, there it is. So the first thing that I want to make sure that you know is that there's a scroll bar on the far right, and in order for you to see all the choices on this poll, you need to scroll all the way to the bottom as well. So the top part of the poll is what setting you're in, and as you go toward the bottom of the poll, you'll be able to check what kinds of roles that you're in. So please take a minute to do that. And while you're filling out the poll, I just wanted to let you know that IPFCC is very committed to supporting you and providing information, and having you share information with each other about how we're responding to COVID-19, not in terms of the clinical approach, but in terms of how we are maintaining and supporting patient and family-centered care. So, so we encourage you to share resources with each other through the chat and also through our PFCC Connect community. We also have a section in our website around COVID-19 at www.ipfcc.org. And so we're trying to get information out and help connect you with other resources. There are certainly a lot of people working in the field on this and care very deeply about this particular subject. So I don't know how we're doing on the poll, Natasha.
We've got about 34% in right now.
Okay, great. So if everybody that wants to can participate in the poll, it helps us know who's in the room virtually, and also allows us to see where we have some commonality, what kinds of settings people are working in, and those kinds of things. So I see that some additional people are logging in, Natasha, so we probably won't get everybody to participate in the poll, but let's go ahead and close it so we can see what we've got going. So over 65% of the folks are in hospitals or medical centers, although I'm appreciating that there are people from continuing care communities, primary care, and ambulatory. And we have a great and large number, 43% of patient and family advisors, which is wonderful. I'll be interested in hearing how you are assisting your organizations, as well as coordinators of patient and family-centered care. So this is great. And the percentages with the additional selections are probably not accurate in terms of the 45% being measurement and quality improvement staff. I'm guessing that because of the way we had to break the poll down, that it is related to the number of people who made those choices in two. So, but it looks like we've got a lot of diversity, both in terms of setting and in terms of roles. And so it's great that you can all be here and be part of this important conversation. If we can close the poll and move to the next slide. So I just wanted to kind of set the stage. We have worked with a number of people who reflected back in another pandemic experience, the SARS experience, about the impact that pandemics have on patients and families. And we have a chapter in our Privileged Presence book about an interview and what was learned from that particular thing. And we will post that chapter in on our website so that you can read more about it. But I think the key is that this is a hard time for lots of different reasons. But the impact of a global crisis on patient and family-centered care was significant during the SARS experience. And what we want to do is we want to learn from that experience. We want to remember that the most important thing is to keep people safe, physically safe, and prevent the spread of the infection as essential approaches. But at the same time, we really need to pay attention to what kind of impact that those separating patients and families will have on them, and there may be long-term impacts, and we want to mitigate those as much as we can. And so the hope for this conversation is that we're able to share what people are doing in their settings, to be mindful of that, be attending to safety, but also being aware of how important that family connection is when people are hospitalized or are in continuing care communities and can't interact with their loved ones. You have to find ways to support that as much as we can in safe ways. You can go to the next slide, please, Natasha. So as part of people registering, we asked people to share what were some of the areas that they wanted to have conversations around. And there were a lot of key areas of discussion generally. What are other people doing? So there was really an interest in sharing best practices. How are people handling the crisis of limited or no visitation? How are people continuing to make sure that patient family voice is included in COVID-19 planning? What guidelines are being used? What are you doing? And then, of course, there was a whole interest in talking about what people are learning about virtual care, because that's happening in a number of settings, and how we support families, and also what is the role of your patient and family advisors. And we've got a lot of advisors on this call, so I'm very hopeful that you'll be able to share some of what's happening in your settings. So those are the kinds of things that we're going to discuss. But before we do, I have one more poll that I want us to fill in, and that's a poll that really is looking at, let's see, based on what people are doing, what are the current policies or strategies that you have in place to sustain partnerships. And so the way this poll works, again, is it's very lengthy, but check any of the things that apply in terms of your policies and strategies. And obviously, if you check no members of the public are allowed to visit patients and restrictions are in place that includes no one can be in the facility, then you would check those two boxes. But if you have some units where you are allowing family presence or inviting, not just allowing, but encouraging and inviting in a safe way family presence in any specific units, you could share that. And then what's happening, there are a number of you in primary care and ambulatory, so what are you doing in your settings? And then how are you supporting virtual options? So let's take a moment for people to fill that in so that we can just kind of see where people are at in terms of what's possible. And then we'll begin the discussion after we see where people are at. So I'll just give people just a minute to do that. I imagine that a number of you are sitting at your homes, perhaps in rooms that you don't normally work out of, so that you can stay safe and be with family. For those of you on the call, we have the ability to mute you, but you have the ability to take yourself off of mute. So apparently Ushma's hearing some noises, and I've moved my papers away from my microphone, so I don't think I'm the one making the noises anymore, but I don't hear any other noises, so maybe I was the epicenter of the noises.
It's better now, Mary.
Yeah, sorry about that, guys. I will keep my noise of paper rustling to a minimum. So Natasha, how are we doing on the poll? Can we close the poll and see what we've got in terms of what people are doing?
You should see the results now.
Okay. I don't see anything yet, but maybe it'll take a minute. So I noticed that there are a number of chats saying that you can't seem to find how to unmute. So in a minute, go ahead, Ushma, and unmute everybody. And Natasha, can you see the results of the poll, or Marie? Because I can't.
I cannot see them.
Okay, I do see them.
Okay. So can you share, Natasha, since you can see them and we don't seem to be able to see them, what kinds of responses we've had on the poll?
Absolutely. So we had 19% say no members of the public are allowed to visit. We had 19% say restrictions are in place that prevent anyone, including family support, from being a loved one in any unit or facility. We had 61% say the following units may have at least one and no more than two support persons present if they have symptoms of the virus. We had 52% say NICU, 65% in labor and delivery, 75% in end-of-life hospice, 58% in pediatrics, 23% in ambulatory or primary care for adults, where no one is allowed in the exam room except for pediatrics, 48% for virtual care, 58% for support technologies, so families can be present. And then we had 21 people who said they have social worker, chaplains, and other staff help support. We had 13 say our PFAC has virtual ways to provide input and resources. 10 said all PFAC activity is on hold until after the pandemic is contained. And 3 said other.
Okay, great. Thank you for sharing that. So we've got people, there's quite a range as one might expect. If we can go to the next slide. So now people are off of mute, and what I really want us to do is really have a discussion now. And I know that there are 80 people on the line, and not all 80 people are going to want to share verbally, but some might want to share through chat. What I want to know is what strategy, we kind of have a sense of the percentage of people that are working on certain strategies, either no visitors or family at all, to yes, we have individuals support people in ICU and other places that can be present, and a number who are working on virtual opportunities. So I'm interested in knowing what strategies people have adopted to support partnership, what's working well, and what did it take. So I am going to just open it up if you want to share something that you're doing.
Yes. Sorry, I'm getting the echo.
So if
We
you
get on more. Hello, can you hear me?
Yeah, if you're getting an echo, it
Hi.
often means that you're
This
on.
is Janice Tufte, and I'm from Seattle, Washington. And although we have concluded for the time all patient family advisors at Kaiser, I presented on a webinar nationally on COVID, as King County was the first organization or the first county jurisdiction that had active cases. And then I was asked by a local institution, academic institution, to be part of their review team, similar to what NIH does, where they have community members involved with reviewing of research projects. So for COVID, I'm doing that. And then at a national level, I'm involved with the Academy of Health, actually, and we're developing out information evaluation opportunities for federal funders for evaluating, guidance and criteria for evaluating projects to fund. And at an international level, I will be reviewing an organization that is wants to include consumers at a internationally and for reviewing crisis reviews. So there's a lot of reviews going on. So basically I'm involved with a lot of reviewing, though I did provide a webinar that I can put into the chat that just tells the basics of what we had here in Seattle, King County, but also an assessment to public health. I'm also involved with public health locally. So I healthcare for the homeless as well as statewide with Title 19 and emergency management. So I sort of understand a lot of the dynamics, and I'm a patient family advisor. And so even though I'm not involved with the health system or receive care, I am involved in other areas. Thank you.
Great, thanks, Janice. There have been a number of both local and international things that you're doing to get the patient family voice into the conversation, and it's great to know that that's happened. We've got a number of other patient and family advisors on the line. Is there anybody who wants to take themselves off mute and share what they're doing?
Mary, I'm hearing a little bit of noise. I don't know if anybody else is hearing it or it
Yeah,
just stopped. Okay.
great.
I think there's a number of people who are unmuted right now. So I don't know if Teresa Rogers, you're unmuted. Did you have something to share?
So it looks like Valentina, you are still having meetings via Zoom with your advisors to keep them up to date. Can you share a little bit more about that? Take yourself off mute.
Hi.
Hi.
Hi. So I'm from Canada, Hamilton. So yes, every 2 weeks we meet with our advisor via Zoom.
Mm-hmm.
And first we update them about what the hospital is doing, what is in community, and how we go forward to make sure that our staff and patients and families are safe.
Mm-hmm.
And we provide opportunities to our patient advisors to ask questions related to how do we keep this going, what we are doing, what are our next steps, but also provide them an opportunity to give us suggestion and recommendation on how we can keep our patients and families connected. And one of which, beside the telephone, so is via iPads.
Mm-hmm.
So we are working on something like that to provide patients and families who are not having an iPad an opportunity to connect with their families and friends and stay connected that way.
Great. And that's a wonderful example of helping people maintain virtual connection. Are you working with your infectious disease folks on how you clean the iPads as you may move them from one patient to another?
Yes, so a guideline. So right now, so far, we don't have the iPads to circulate around because yes, the infection control and a group of staff is working to develop those guidelines. We have one of our patient advisor part of the IPAC group, so.
Mm-hmm.
So that was the first question that our patient advisors, when we provided them with this suggestion, was asking. So how do we clean the iPads between the patients?
Great, great. Ginny Schaefer, I see that you are still considered an essential person and you are a parent navigator. Can you talk a little bit about what your role has been like during this time of COVID-19? And for those of you that might not be talking, if you can put yourself on mute, that would be great. It may be that Ginny isn't able to join us on audio. So is there someone else who's working as a patient parent navigator or a PFCC coordinator who can talk about how their roles changed during the COVID-19 pandemic?
Yes, hi, I'm Mandy Frank, and I'm from Baton Rouge, Louisiana.
Great.
And I work with our hospital, Women's Hospital.
Mm-hmm.
I personally am not on site at the hospital, but I have been connecting with our med schools and with our local Tulane university that has the oldest public health institute. I haven't been back at the hospital because I have been in classes with people from Italy, so I've self isolated. But I have been working with the university and individuals to talk about COVID research along with the NICU impact.
Great, great. And who are you working with primarily?
I am currently working with a dean of the Hospitality Institute. That is
Uh-huh.
a joint venture between our healthcare EMBA program and the MBA program to do the statistics. We are drawing upon researchers for the staff, but we're looking for ways to bring the parent role in outside of the medical records so that they have the communication, they have the backbone, they have a parallel network to the ERM, the medical record, so that it can carry with the parent for the rest of taking care of the baby after the NICU and you go to pediatrics and then support you through the whole life cycle and
Great,
not be tied to a particular medical.
wonderful. Well, thank you for sharing. I see that Joanna Salenza is on and chatted something in. Joanna, do you want to share a little bit about what you're doing as a family support specialist?
If people are having trouble, Mary,
Mm-hmm.
speaking, because Joanna just went off mute. Joanna, are you there?
I am here. Is there an echo though? I think the sound is a little challenging.
It is. Sometimes people get echoes. Did you call in on the phone or are you just using your computer?
I'm just using my computer so I can chat in instead of using the microphone.
It seems to be better. Why don't you just help a little bit?
Okay. So I chatted in that I chair our advisory council. So one thing I've tried to do is maintain connection with them because they're a fabulous resource for all of our work in our intensive care nursery. So that strategy has been helpful as we've had to communicate policy changes and things are ever changing, and just having a resource and a connection to frontline staff and our leadership team, that to me has been really helpful, being able to leverage technology to stay connected to that group, because I'm working remotely now. I'm not on site.
Mary, you're on mute.
Oh, oops, sorry. It is really important to maintain those connections with your PFACs when you're not able to continue face-to-face kinds of meetings. I noticed in the chat that Ginny was talking about something that I think is really important, which has to do with language. And one of the language, and I know she's having trouble with her thing, but I love that she's rounding every day to inform on restriction updates, but they've changed the language from restriction to protections, which I really think is a nice softening of the language, but also really clearly indicating why and what the purpose is by using the word protection. So I love that you shared that. What other kinds of things are working well for people?
Angela Miney has a interesting population that they're caring for. So I don't know if Angela can unmute, but there's a nice chat about because they're working with patients with cystic fibrosis. And Angela, I think you're off mute. Can you?
Sure. So I am a family advisor who works within a pediatric pulmonary division. So I have a full-time position with them, and then we also, we serve the population of patients with cystic fibrosis within that division. And we also have a cystic fibrosis advisory board. So our team have been very active in thinking and strategizing about how we can actually keep the patients with cystic fibrosis out of the hospital, because obviously they are a very at-risk population. And so we did a very comprehensive newsletter out to our patients last week. Members of our team are currently calling all of our families. I helped to update an email list. So we're calling to just check in with people, see how they're doing. Obviously, that's very time consuming. So I think it's very, I mean, I'm very appreciative that our physicians and our nurse practitioners are doing that. But in addition to that, we had an emergency, if you like, meeting of our Family Advisory Council yesterday, because we wanted to talk to our advisors about how best to connect with our patients and families. So there's so much information out there. I think we're all getting really overloaded with the information, and we wanted to talk to our advisors about how best to serve them. And one of the things that we're going to do is an at their suggestion. So people are appreciative of frequent email updates from our team, because of course the people who are taking care of the patients are the ones that we trust the most. So in addition to planning kind of a weekly email, we're also going to do a Zoom conference for all of our patients and families, where we can give them information about how COVID-19 may affect somebody with cystic fibrosis, try and give them information about how we can treat them at home, how to keep them out of the hospital, to keep them safer, and then kind of do a Q&A session.
Right.
And I've just been on a 2-hour call with our entire team, strategizing all of that. So it is very much on our minds.
Great. What a very comprehensive approach. And very much staying very connected with people and sharing useful information. I love that. We've had a couple of people in chat say that they have something to share, and I told Sandra Rush that I would have her share next, and then Kathy Quinlan, I'll have you share after that. Sandra Rush is from Common Spirit Health. Sandra, can you take yourself off mute and share what's going well and what strategies you have in place?
Okay, go ahead. Can you hear me?
Yes, I can.
Yes.
Mm-hmm.
Okay, great. Thank you. So at Common Spirit Health, we have over 152 hospitals. And so what the patient experience improvement team did for the system is created a resource guide for patient experience during a pandemic. And so things that we included in there included adaptations to the evidence-based practice. So understanding that bedside shift report is being modified with patients in isolation. We talked about how you could still accomplish that through the use of iPads and other technology. For patients not in isolation, we included calling the family during bedside shift report.
Mm-hmm. Mm-hmm.
Leadership rounding is done by phone calls into the patient. And so that was another suggestion to the hospitals. And then we also included that key communication with patients and visitors to make it more patient and visitor friendly, using words that were not, you are not permitted, but more of the patient inclusion wording. And then reminded everyone for our patients in isolation, that we make sure we introduce ourselves each and every time that we go in. And encouraging constantly, whenever there's any communication with the patient, discharge information, instructions, nurse physician rounds, and then of course that bedside shift report, calling the family. And then we also included information for staff, because we have to really make sure that we thank them and let them know how important our caregivers are in caring for the patients. And so some ideas around leadership being at the entrances first when staff come in and leave each day. And then reaching out to the patient and family advisory council boards to send emails or letters of gratitude to our caregivers so that we can post them.
What a great idea. Is that a resource that you could share with us, that we could share more broadly? Because it sounds like you had a lot of really good ideas that were really practical and also very mindful of the position that staff are in.
Sure. Well, I'm double checking on that.
Okay.
But as soon as I get the okay, we'll send it.
That'd be great. Thank you so much for sharing, Sandra. Kathy Quinlan, and you had your hand up. So would you like to share what's going on in your setting? I
Kathy,
see.
yeah.
I
She's
see you're off
unmuted.
mute. But I'm not sure that I hear you.
Kathy, if you'd like to chat in what you wanted to share, because I don't think we can hear you, even though you're not on mute.
Great.
Oh, she says she's not able to unmute, so
Okay. Well,
please chat
Kathy,
in.
you can chat it in. That would be great. I appreciate everybody sharing in chat if you're unable to share in using auditory things. Are there others that are on the line? I know that Bridget Gavin was hopefully going to be on the line, and they're doing some nice things in at University of Minnesota. Bridget, are you on the line?
I don't see her in the participant list, Mary, unless she's on the call. We do have a great comment from Janet Rodriguez. So it's how to address the non-medical updates. So, we know that poverty makes people sick and disabled. How do we step out of the biomedical model and allow space for conversation on finances, loss of job, etc.? So I don't know if others want to respond to that. I think it's, that's a very important concern in these times.
It certainly is. I know with social determinants of health and the homeless population and individuals who are at risk and being very vulnerable, that we need to be sensitive to that. And I wonder if a number of organizations are working with their outreach workers or their social workers to address some of these issues.
Hello.
Hello.
Hello, this is Janice. I could touch on that from Seattle. So Healthcare for the Homeless is a national organization. Most of your larger jurisdictions have a chapter. It's usually a nonprofit. I'm involved with the Healthcare for the Homeless. It's county administered. And we have a very robust group of outreach, and we've been very fortunate that our city has opened up its event, our event areas, and created more shelter space, because before the shelter beds were too close to each other, which could be a quick source of infection. There was no way they could spread them out for 6 feet. So they've opened up multiple event centers, and so they've been able to accommodate in that way. We also, our county purchased a small motel that's for individuals that are experiencing homelessness or they don't have a place to effectively isolate. It could be somebody, it might be even, you know, a worker, agriculture worker that, you know, shares space with 10 people, and so they need to have a space. We also have 3 different locations of modular units, and there's one page on my webinar that address, you know, it's actually just a slide deck that tells about this, but I'll put a link into our local COVID-19 healthcare for the homeless, and you can browse through it. It's really recognized as one of the top in the nation. The United States Interagency Council on Homelessness really refers to our efforts here on their page. Thank you.
Great. Thanks, Janice. I noticed that there was a question about if anyone on the line, and we know we have some people on the line who are in a practice setting, ambulatory or primary care, and they're interested in any strategies that they have, that you might be using that have to do with communicating and engaging patients and families. Good messaging that you've seen used or are using. Is there anybody that has something that they want to share related to that? I do know, while we're seeing if somebody comes off mute, I do know that at Children's Mercy Hospital in their primary care setting, that their patient and family advisors helped craft a message related to when they had to contact people to cancel appointments or offer telehealth. And that message was fairly strong, and it is available in the slide deck from the webinars that we did last week, sharing some best practices. And so I encourage any of you that want to see some of those examples to feel free to go out to our PFCC website and listen to the recording or download the slides. Probably the fastest way to get to the language would be by downloading the slide. Notice that Isabella is talking about implementing trauma-informed care alongside shared decision-making as being a very important for people to be considering.
I'm hearing some feedback, Mary.
I'm not sure why.
I'm wondering if everyone could just mute again.
Hello, I would like to ask a question.
Yes.
So my name is Janet Rodriguez, and in our PFAC, we cancel our March meeting, and we're really hoping to get into the technology and Zoom capacities. So I'm going to share this with our group. My concern is if we are still just like at this moment, all the focus is on how to save this person's life, how to make them breathe so they can leave the hospital, go home. That's great. But will they have a home to go to if they're evicted? If they don't know that there's been resolutions or orders or programs that will help them when by the middle of April, they leave the hospital. In the meantime, they're going to be spending all this time suffering in mental anguish, thinking, I may not have a place to go to. The other option, the other part of this is that right now the hierarchy between who makes the decisions and who makes the recommendations is inevitable, because obviously we need to save lives. But there's a lot of conversations on benefits for citizens, but when you are not a citizen, you still get sick, you still end up in the hospital. There's a lack of inclusion for who gets whatever supports and who can participate, whose voice is represented, and those who don't have status for whatever reasons. Or I've heard, people are talking about programs for homeless folks, but also those in prison. So we need to try to, from our patient perspective, try to bring the social determinants of health points of view. And if anybody has had success on how to do this effectively to reach whether to their group or maybe their hospital board of directors, I would appreciate that.
Great. So it sounds like you're asking for resources of ways that people have treated and been mindful of creating safety for a number of other kinds of vulnerable populations besides the homeless, the undocumented residents here. I do know that Contra Costa's website, they're down in this, the California area, has good language on their website about inviting people, regardless of their immigration status, to receive care and be protected while they're doing that. So that's certainly one thing. Do other people?
Mary, could you, Bev would like to respond?
Yes, Deb, please.
Thank you, Mary, and thank you, Janet, for very thoughtful comments about this complex issue. And I'm wondering if a resource to you, but others on the call, would be to reach out to the diversity and inclusion officers of your healthcare organizations. It may be the health equity person, it might be diversion and inclusion. There are a number of different titles, and these people may not be, on the front lines providing clinical care, but to invite them to have a conversation with the PFCC leaders and the PFACs and to work together on these important issues, I think might be helpful. The titles for these leaders that are trying to help us be more responsive to the real issues of social determinants of health vary, but I'm sure that most of your organizations have somebody like that, and they may not have had conversations with your PFACs. Thank you.
Great idea, Bev. Thanks for sharing it. Equity offices also can be useful resources. And this also is a time to reach out to partner with some of our community agencies that work with some of the populations that were described, because those advocacy groups can often help healthcare organizations create practices that are respectful of those groups. So I'm wondering, what challenges are people still facing that they want to chat about, and maybe get some ideas from others about how they might address those challenges?
And we have had a number of questions, comments about telehealth. So if anyone has great ideas to share about setting up telehealth programs at your clinics, centers, that would be terrific as we think about challenges.
I know that they have reduced restrictions on the kinds of devices that can be used for connection. And so some organizations are even using FaceTime on phones if they don't have the extensive telehealth equipment that some larger organizations have available.
This is Wendy in Louisiana. May I ask a quick question? Have
Sure.
people been able to get through their hospital administration to have a channel on the backbone of the telemedicine for parent conferences or parent meetings or any of the non-medicine protocols?
That's a good question.
We've been kind of embarking upon building a parallel system next to it rather than fighting the permission of getting involved in the hospital, on the fact that we get that there's just too many unknowns and that it's hard for them to say a yes in telemedicine.
Mm-hmm.
To leave that bandwidth for medicine and create new bandwidth for the social sides of medicine and the recovery side, and that it's a it's not urgent care, it's restorative care, and trying to create a second line, which is a new concept for hospitals. But our mayor in our town already initiated that recovery for us is going to look different than it does for like natural disasters, for like hurricanes. And so we thought of building out this time by pushing for that second line that connects closer to our 211 systems, so that non-medicine services can participate in it, but that it's kind of joined at the hip with the telemedicine line, but leaving telemedicine bandwidth for urgent care and not trying to compete with it or consume it. Does that make sense?
Yes. That sounds like
Now,
a really good strategy.
well, we're at the beginning of it. We're at the very beginning of it. And that's why we're pulling as many resources to invest in it, like either in conversation, politically say, yes, I see the need for that, and two, to help us initiate the architecture for that, which is going to be way broader than a hospital, because 211 is a community resource, and eventually it wants to be portable with every hospital, but it's guaranteed that if parents get on a tool, it can take them through the continuum of everything they're experiencing, whether it's healthcare, economic, natural disaster, just all kinds of counseling services, even if they're introduced to it inside the hospital. That the growth capacity will be there. I think what we're looking at is we're trying to swim up the wrong tree if we're asking to be on their bandwidth for diagnosis. That we might need to be on a second bandwidth. Now, having said that, we're at the beginning of it.
Yeah.
And we don't know how it's going to play out. I was just wondering if maybe in Kings County or somewhere else where you're maybe a little bit more progressive. However, when it comes to emergency response, we're pretty progressive here because we have had so many disasters.
You bet.
But, and we're kind of really tired of it,
Yeah.
honestly. But the idea is if we could build it out correctly, it's just living in our coastal environment, you know?
Thank you so much for sharing what you're doing in Louisiana. Tell me your name again.
Wendy French.
Wendy French. So as you continue to move this strategy forward, would you be willing to continue to be in conversation with us about what you're learning?
100%, yes.
That'd be great. What I really appreciated is the whole idea of thinking not only of this acute situation that we're in, but also thinking about the recovery aspects of it.
Correct.
Are you working with a particular facility in Louisiana? We've got a lot of chats coming in because they're interested in what you had to say about this particular situation.
Yes, I am working primarily with Tulane University and Women's Hospital here in Baton Rouge. I am a parent of an NICU. She's 20 years old now, but I have some emergency response as my career, as my profession. So, so that's why I actually helped our county set up our 311 and our 211 system. So this is why I'm kind of looking at it from that lens. We also have a collaboration with our politicians and our insurance companies and Auctioner Health System in New Orleans and Tulane's Health System in New Orleans. So we basically have all of the players on board, but taking care of telemedicine has been our primary source. And now we're wanting this voice to be the second line behind telemedicine.
Yes, sounds like a wonderful collaboration with a lot of diverse perspectives being represented. Thanks so much for sharing, Wendy. Erica Bowen made a comment in the chat about some things they're finding out related to food insecurity related that they're finding out during telemedicine visits. Erica, are you able to share a little bit more about that experience?
Sure. During the visits, the telemedicine visits, we're realizing that our patients just don't have the food or the income or the resources. So we partnered with our local food bank to ask 2 food insecurity questions. And if they answer yes to these questions, those questions are, let's see, if you don't mind me asking, do you have enough food at home? And can you afford to buy more food, or could you use a little assistance? And so if they do say yes, then we will assign our promotores to look into that particular patient and try and help respond and answer the questions. And we've partnered to help fulfill their needs. And then we've partnered with our local food bank so they can get them food. So there's like an emergency food. And then our faculty have, we've asked all our faculty if they would like to make a donation. And so we have a Venmo account set up. And so then we'll deliver the emergency food and then $20 to the family at that directly.
That's amazing. That's great. And the fact that you were mindful enough to ask those really important questions in this time of focus on COVID-19 and the crises that it's creating that go beyond just health because people are staying at home and not having income and those kinds of things is wonderful. I am just amazingly astounded that it is now 3 minutes to the top of the hour and we have just begun this conversation. I need to be respectful and kind of wrap this up, but if we can go to the next slide. For those of you that have joined the conversation but aren't necessarily members of PFCC Connect, we encourage you to join PFCC Connect because that's where we're going to be continuing this conversation. Can you go to the next slide, Natasha? We have created within PFCC Connect a COVID-19 community, and we will put today's conversation in the chat record, today's slides, and any relevant IPFCC links to that community. And we encourage you to join the community, add additional suggested links, examples, and tools. And I know a number of you have agreed to share tools with us. If you're having trouble getting into the COVID-19 community on PFCC Connect, or you don't know how to load documents up, please reach out to me and I can help facilitate that process. We also have Marie's putting some additional resources in the chat, and we want to continue the conversation and the questions in our chat. If we can go to the next slide. The other thing that we're thinking about doing, and what I want to do is really thank you for being part of this conversation. I think that you are important helpers in this time of crisis, and your interest and your compassion and your passion around creating and maintaining and enhancing those partnerships with patients and families and responding to the needs that are out there are so important. And that really gives me hope and others hope, as Fred Rogers liked to say. We're going to ask you to fill out one more poll before you leave, because it's a poll about whether you'd like to continue these conversations on COVID-19 on some kind of a regular basis. So if you can, Natasha, open up that poll so people can fill it out. We want to make sure that you give us feedback about whether or not we need to, maybe weekly, maybe every other week, have conversations so that we can continue to share our learning and our examples and the challenges that we're facing. So, Natasha, are you going to be able to get up the poll?
I've got it launched right now. I'm seeing if it'll take. There seems to be a big drag in the polls right now.
It may be because we have so many people on the call. I think we're kind of taxing technology, as I've heard others are, because we're really going to a lot of virtual kinds of connections. So if the poll doesn't show up, if you can chat in whether you'd like to continue these conversations and whether you'd like them weekly or bi-weekly.
Can you see the poll, Mary?
And we would like for you to evaluate how today went and ways that we can improve this for you. And we're gonna kind of give everyone a chance to be sharing, working in chat. So we'll stay open a couple more minutes for people to get that chat in before we close things, because we want to be responsive to your needs. And of course, now the poll comes up.
And here's the poll.
Yeah. So if you haven't chatted in, because we'll include both what's in the chat and what's in the poll, if you can quickly click on the poll, that would be great. I want to, as you're working on the poll, I want to thank you all for the important work that you are doing in your communities. It's tremendously inspiring. The fact that so many of you as patient and family advisors have joined this call and want to make a difference and want to be in conversation and partnership with your healthcare organizations. And those of you in healthcare organizations that are continuing to reach out to respect your partnership with patients and families and your awareness of how very important it is that we keep those connections between patients and their families as present as possible, whether it's virtual, whether it's identifying a caregiver and encouraging that one caregiver to represent family physically in NICU, in maternity, and other kinds of places. It's really important during this time that we connect with each other and continue to share inspiring stories and share strategies and practical tips that have been learned out on the field in the front line that are making a positive difference, because we want to share those very broadly with others, because people are really asking for guidance in this area. Marie, did you have anything else you wanted to share about the chat that maybe I haven't brought attention to?
No, but I do see that people do want this conversation to keep going. And it looks like bi-weekly, I don't know what the poll is telling us, but bi-weekly would be terrific. So just keep in touch with us. And as Mary said at the beginning, we are creating a new section of our website devoted to how do we keep advancing patient and family-centered approaches to the pandemic, and we would love for the sharing of resources to continue on that site as well.
Great. Thanks, everybody. And you take care and be safe out there.
Do you see the poll?
Yep, I see the poll. Looks like every other week is the top vote getter. So we will get that started and make that happen and communicate with you when those dates are going to be. Thanks so very much for joining us, and have a good day.
Thanks.